Um, Hello, everyone, and welcome to Grand Rounds. We're honored today to have Dr. Prasad Devarajan present the 12th annual Dimitri Ellis Lecture. As a reminder for those attending virtually, questions can be posted in the Q&A throughout the lecture, and you can join us for an informal meet and greet after the Grand Rounds. The CME and Maintenance of Certification Part 2 codes will be posted in the chat and displayed in the back of the Rangos Auditorium. So Dimitri immigrated from Greece to the United States at the age of 13 and went on to realize the American dream by becoming a pediatrician. He completed his residency at Children's Hospital of Pittsburgh and then returned to Pittsburgh after his fellowship to both initiate and lead the nephrology program for 40 years. He taught students and residents, looked after all the children with diverse kidney disorders throughout our region, and carried out clinical and laboratory-based research, a true academic triple threat. His clinical expertise is nationally and internationally recognized, particularly in the field of pediatric kidney transplant. His patients were the first children with kidney transplants to receive cyclosporin or tacrolimus immunosuppression, and superior outcomes have distinguished children's as amongst the top pediatric kidney transplant programs. He was awarded the 2011 Howard Mermelstein MD Award for Excellence in Pediatrics. He published more than 100 peer-reviewed papers and 28 book chapters. He served as a principal investigator for NAPROTEX, which is our study for kidney transplant patients. He officially retired in 2017, and today we are honored to celebrate him, his 40 years of service to the children in our region with this lecture series. And we're pleased today to welcome Prasad, who is the Louise M. Williams Endowed Chair, Professor of Pediatrics and Developmental Biology at Cincinnati Children's Hospital Medical Center and the University of Cincinnati College of Medicine. He's the Director and CEO of the Dialysis Unit and ESRD Program, Medical Director of the Stone Center, Director of the Biomarker Laboratory, and Senior Medical Director of BioPorto, among many other leadership roles in pediatric nephrology. He leads an outstanding program in acute kidney injury that truly spans basic science, translational medicine, and clinical research. He's mentored countless trainees and has supported the early careers of two prior Pittsburgh pediatric nephrologists, Elif Erkin and Agnes Schwittecker-Urban. He's received many awards, including a Special Achievement Award for Distinguished Service by the AAP and the International Society of Nephrology's Academic Excellence Award, and he's maintained NIH funding for over 35 years, published over 340 peer-reviewed publications. Among many other discoveries, he's perhaps best known for his work on biomarkers of AKI, including NGAL, which we have just started using clinically here at Children's Hospital within the last month or so. He has truly spanned the breadth from bench to bedside. So please join me in welcoming Prasad for this Ellis Lecture.
Wow. I wish I had recorded that and I can send it to my mom. She's still wondering why I became a pediatrician and not taking care of her as she ages. But anyway, thank you all for being here. You will not understand what a tremendous privilege it is to be here in honor of Dr. Ellis, who has contributed and taught so many generations, my generation, at least 2 or 3 above me, and at least 2 or 3 below me, the essentials of pediatric nephrology. His teachings are still what I teach my fellows. And so it really is a tremendous honor and a privilege to be doing this. And you're all so lucky to have been, for him to have been here for the last so many years. So cannot emphasize that. But I'm going to talk to you about biomarkers of acute kidney injury. And I'd like to start with a disclosure that I am also one of the hats I wear is I'm the Senior Medical Director at BioPorto Diagnostics, which manufactures the NGAL biomarker assay. But I have to tell you that I provide only scientific and clinical advice, and I have no financial conflicts of interest, unfortunately. But what are we all going to talk about today? We're going to talk about why do we even need novel biomarkers of acute kidney injury? And if I can convince you that we need them, how are they discovered and translated? And what is the current clinical status? Let's start with why do we need novel biomarkers? Now, the KDIGO, or Kidney Disease Improvement Global Outcomes Group, which is a think tank of nephrologists and critical care doctors across the world, get together once in a while and put out these white papers, these guidelines. And they put out this definition for acute kidney injury, which everybody in the world uses, mostly for epidemiologic studies. They said it's an increase in serum creatinine by 0.3 milligrams per deciliter within 48 hours, or an increase in serum creatinine by 50% from baseline within 7 days, or urine output less than 0.5 ml per kilo per hour. And so clinically, you can program your EMR to make this diagnosis even without seeing the patient. And that's what many, many places have done. But look at it carefully. It's completely dependent on changes in serum creatinine or urine output. And that, ladies and gentlemen, is a big problem. Why is it a problem? In terms of serum creatinine, you all know this, but I'm going to remind you, it is artificially reduced in our patients in several clinical situations. And therefore, in those patients, that creatinine is never going to go up, even if there is true structural acute kidney injury. We're talking about patients with decreased muscle mass, malnutrition, chronic illness, sarcopenia. Within 2 days of hospital admission in the ICU, our patients get sarcopenic. That's been recently shown, and their creatinine actually goes down instead of going up. Sepsis, same thing. Creatinine generation goes down. Fluid overload, of course, that makes sense. Dialysis, it removes creatinine. So in all of these situations, creatinine is absolutely useless to determine who's got acute kidney injury, especially the structural injury. And the last two pertain to our neonatal patients, IUGR and prematurity, all of which can decrease, artificially reduce serum creatinine. On the other hand, it can be artificially raised. Serum creatinine can by dehydration, maternal creatinine in our babies, diuretic use, of course, and a whole host of medications that interfere with creatinine secretion. So in all those cases, you're going to make a false positive diagnosis of AKI. The kidneys are going to be pristine, but the creatinine is going to go up, and you're going to label this patient as acute kidney injury erroneously. Urine output is no good either. It's really difficult to measure accurately. It's affected by hydration and, of course, diuretic use, affected by gestational age. So all of these problems put together really makes the diagnosis of acute kidney injury imprecise and delayed in the clinical setting. So going back to the clinical setting, we now know the top of that figure shows that transition from acute kidney injury to acute kidney disease to chronic kidney disease to end-stage kidney disease. And I could spend days talking about that, but the take-home message is acute kidney injury very frequently leads to chronic kidney disease and even end-stage kidney disease, especially the kind of AKI that we see in our sick patients today. And along the way, there's a whole bunch of complications, including death, unfortunately, that these patients go through. But we'll focus on these 5 bullet points here. Going from green to yellow to orange to red. In clinical medicine today, we live in the red zone. We live in the zone where kidney failure has already occurred. The glomerular filtration rate has already gone down. It has been going down for a while, and there's been increasing damage to the kidney. And we can diagnose this by using biomarkers of glomerular filtration or functional biomarkers, such as serum creatinine and cystatin C. But I would argue with you, and I hope to convince you, that we need to be in these phases. We need to identify this damage phase, where there is actual damage to the kidney, but the serum creatinine is normal. And that's because of the phenomenon of renal reserve, whereby you need to lose at least 50% of kidney function before your creatinine even begins to budge. And a great example is living donor kidney transplants. You can take out one of my kidneys and give it to a recipient. And 1 year later, 10 years later, my serum creatinine is still normal. I've already lost 1 kidney. My function is down to 50%, but my creatinine is still normal. So the good Lord gave us 2 kidneys so that we can donate 1. So that's the damage phase. And there's already occurring damage, and that's a condition called subclinical acute kidney injury, which we miss completely in clinical medicine today. And I will hope to convince you that's an important identification to do in one of the subsequent slides. So we need to get to this yellow phase and orange phase, because at this phase, you're going to reverse the injury, and you're not going to allow this inexorable progression to chronic kidney disease and end-stage kidney disease. How do we get there? We need structural biomarkers. We need markers that can identify structural injury way before the function goes down. And the two best studied structural injury markers are NGAL and the cell cycle biomarkers. The TIMP2 IGF-BP7 were actually identified and validated right here in UPMC by the group there, John Kellum and his group. I'm not going to talk about that. I'm going to talk about NGAL, which is my baby, which is what we identified and is the only one that's FDA cleared in children. So let's talk about NGAL. But before we go there, I just want to put this whole thing in perspective, structural versus functional markers. And we'll look at two common conditions in medicine that cause damage, right? One is myocardial damage and the other is kidney damage. And you all know over the last several decades, we've had these increasingly sensitive and specific markers for myocardial damage. And these are damage markers. They're not functional markers, but they do this all the time. You go with chest pain to the emergency room. Before the cardiologist sees you, he'll say, what's the troponin? Right. And that has resulted in multiple therapies and a 50% reduction in mortality. During these same decades, we in nephrology have made the following progress. Functional markers. Okay, we have not had damage markers, and all we've been able to provide is supportive care, including dialysis, and that has continued to have a high mortality. So we really need these damage markers of kidney damage for better treatment, not only for better identification, but for early treatment and better treatment. If I've convinced you of that, I'm ready to tell you how these novel markers may then be discovered and translated. Serendipity, luck. Be open, be unbiased. And so over the last 2 decades, many groups have used these unbiased gene analysis methodologies, cDNA microarrays, genomics, next-gen sequencing, and they look for changes in kidney gene expression following acute tubular damage. And then when we reviewed this back in 2015, 10 years ago, already there were 150 publications, and they all said the most commonly upregulated gene and protein in tubular damage is NGAL. They all said that's the number one. We didn't know what NGAL was at that time, so we went chasing it. But before that, we also looked at the proteomic analyses that were published 10 years ago. They said the same thing, more than 30 publications at that time. So when we mined all this data, the one thing that kept coming out is NGAL, NGAL, NGAL. So we decided to chase it. NGAL stands for neutrophil gelatinase associated lipocalin. It was first discovered as a small 25 kD neutrophil secondary granule protein. It's produced in the neutrophils as the neutrophil matures as a secondary granule protein. But there's also normally small amounts of this protein present in epithelial cells of organs that are facing the outside world, the lungs, the colon, and the kidney. And in those organs, it has a very important part of innate immunity. It sops up iron, and it's bacteriostatic, and it protects us from infections and bacteria coming from outside. And so it's bacteriostatic and therefore nephroprotective. And we could talk for days on the nephroprotective, but take my word for it. But like I said, published 25 years ago, the most upregulated early gene and protein in the kidney, in the urine, and in the plasma after acute tubular damage. So like 25 years ago, and now there's more than 2,000 publications. I'm not going to go through 2,000 publications, don't worry, but I'll tell you a few of them. And I'll start with some that came from my lab, asking the question, well, what is the NGAL protein doing in the kidney? So this is what it's doing. So we put together a bunch of different animal models of acute kidney injury. The one I'm showing you here is an ischemia reperfusion model where we clamp the renal arteries on both sides for about 30 minutes and then allow reperfusion to take place. And when we do that and measure creatinine serially, it takes 24 hours for the serum creatinine to go up. I've done the injury today. The creatinine doesn't go up for another 24 to 36 hours. Well, what happens to the NGAL in the kidney? So if we take out a piece of the kidney within 1 hour of the injury, not 24 hours, and stain it for the NGAL protein, this is what we see. The whole thing lights up like a Christmas tree, not in the glomerulus, but also in the but mostly in the tubules. And if you take two tubules that are kissing each other right here and do a high power, This is what it looks like. This is classic punctate cytoplasmic distribution, very reminiscent of a secreted protein. This is what secreted proteins look like. And indeed, if you look in the lumen, there were red dots in the lumen. And I promise you, this was the 90s, but we were still not smoking anything, but there were definitely red dots in the lumen. Okay, that told us that the protein is being secreted and is appearing in the lumen. Nobody believed it. They said, showed it another way, so we did a different kind of stain, and same thing. The tubules had this punctate distribution. Look at all that brown in the lumen. So that was our aha moment. That was our tipping point, because that told us, hey, start looking in the urine. Could that be a non-invasive biomarker? You know, the urine is a window to the kidney. And so can we use urinary diagnostics to determine what's going on in the kidney? And I would not be standing up here if the answer was no. The answer was yes. In that same animal model, the first drop of urine that came out within minutes was blazing positive for urine NGAL, whereas, like I said, creatinine doesn't go up till 24 hours later. This is the Western blot. Very nice. We got it published in top-notch journals, but that's not very practical in the clinical world. What do we need to do to take this basic science and translate it to the human? And the first thing we needed to do was to create an ELISA, which anybody in the world can use and measure. And this little panel up here, that's 5 years of work, just saying, and about 4 postdocs, but they got it done. They took that assay, created an assay that you can use to measure NGAL in human blood, human urine, human serum, human saliva, human whatever. And then the big change was we were able to partner with industry and convince them that this ELISA is worth putting onto any standardized clinical laboratory platform. So now anybody in the world can do this test, including here at Pittsburgh Children's. So you have, thanks to your clinical lab directors, as well as your nephrology and critical care docs, they have taken this assay and put it onto a standardized lab platform. Any of you can measure, can order it. You'll get the result in 30 minutes or less, and it's very accurate. So that's where we are. And that has created essentially an explosion of studies using NGAL in several clinical situations. And that's what we're going to talk about next. What is the current clinical status? I'm going to focus on these 3 buckets: cardiac surgery, critical illness, and nephrotoxins. But the truth is, it's been studied in about 25, 30 different situations that cause AKI. Just don't have the time to talk about all of those. But in these 3 conditions, you can use NGAL to not only predict future tubular injury, but more importantly, probably to exclude it. You can use it. The negative predictive value is 99%. So you can exclude kidney injury very effectively. And I'll show you the data for these 3 conditions. We'll talk about differential diagnosis. AKI is not AKI is not AKI. There's some AKIs that cause true tubular damage, and there are some that are functional. And in both those cases, your creatinine is going to go up. Can we use a structural biomarker to differentiate between the 2? What about prognosis? Patients in the ICU has AKI. Who's going to need dialysis? Who's going to die? Can we use biomarkers to predict that? I hope to show you the answer is yes. Can you use NGAL for determining when to start dialysis? Initiation of continuous renal replacement therapy. And finally, can you use it to stop renal replacement therapy? So these are some of the bullet points that I'll go through very briefly. For each of these conditions, I'm going to show you the landmark study that first showed this, and then nobody believed that study, and then I'll show you the meta-analyses of hundreds of papers that have come after that validate the initial findings. So let's start with cardiac surgery. And by the way, most of these studies, the landmark study was done in pediatrics, in children, and the adult nephrologists and critical care doctors followed much later. We are the pioneers. So this is the first cardiac surgery study that we were fortunate to publish in the Lancet about 20 years ago. And it's such a simple study. 71 children undergoing cardiopulmonary bypass, just measured urine and blood NGAL before the surgery and serially after. And we defined AKI, as KDIGO told us, to 50% increase in serum creatinine from baseline. So in these patients, just like the mice, It takes 1 to 3 days for the serum creatinine to go up. What does the biomarker do? That's what it does. The urine NGAL is on the y-axis. Time after cardiopulmonary bypass in hours is in the x-axis. And the blue line represents patients who never developed an increase in serum creatinine, never developed AKI. Look at that. It stays nice and normal. So the negative predictive value is very high. But look what happens to the patients in blue who subsequently developed acute renal failure based on an increase in serum creatinine, which occurred 1 to 3 days later. Within 2 hours of starting the bypass, they had a massive increase in urine NGAL. Within 2 hours. The patient is still in the operating room. The chest is still open. The cardiac surgeon is still working on those lesions. First drop of urine that comes out, blazing positive for NGAL. Throughout the 5 days of the study, it stays up, although it peaks at about 4 to 6 hours and starts going down. And these are patients with mild to moderate AKI. If they had severe AKI, it will continue to skyrocket and go into the thousands and many thousands. So this is what we published. Nobody believed it. They said, show me the diagnostics, show me the diagnostic accuracy of this. In order to do that, we had to do what's called as a ROC curve, a receiver operating characteristic curve. It was rocking and rolling, and it's simply just a sensitivity versus 1 minus specificity. And just to tell you that there's an area that we calculate under that, an area of 0.5 is a coin toss, 50%. An area under the curve of 0.75 is a really good marker. And that's where these troponins live today and have lived. So cardiologists have accepted an AUC of 0.75 as a very good biomarker. For example, using troponins for diagnosing MI. And then if you have an AUC of 0.9 or above, that's outstanding. That's almost unheard of in medicine. So when we put this ROC analysis to that cardiac surgery patients, this is what we got. It wasn't even a curve. It was more like a box, right? So what this showed is that for the 2-hour urine NGAL, the area under the curve was 0.99 for prediction of AKI, which is drop dead gorgeous. Because the translation of that is what it means is that this patient is in the OR. The first drop of urine that comes out, you send it to the lab. In 15 minutes, you get the results, and you're 99% accurate. Who is going to get an increase in creatinine 1 to 3 days later? Nobody believed it. Yeah, even though we published in the Lancet, nobody believed it. Luckily, the ELISA was available, the clinical test was available, and everybody and their uncle tried to do this. And here we are, 20 years later, and this is a recent meta-analysis of NGAL and other biomarkers in acute kidney injury, specifically after pediatric cardiac surgery. And we'll show 56 papers have been published since that first one, 49 biomarkers, more than 8,600 patients with AKI. AKI was always defined in the same way, and by far the urine NGAL in all of those studies was the best performer with pooled AUC of greater than 0.8, pooled AUC better than troponins. It has stood the test of time, 25 years. Across the world, everybody finds the same results. I'm so happy. Serum NGAL also works pretty well. By the way, I'm showing you all the urine data, but the serum also works very well in the AUC of 0.7 to 0.8. And just to keep the adult practitioners happy, these markers also work very well for AKI prediction after adult cardiac surgery. So when I get my MI, I'm going to tell them, don't check my troponin, check my NGAL. Okay, what about critical illness? This is the first landmark paper that we published in the Annals of Internal Medicine. We just took patients from the emergency room that were admitted to the hospital. These patients had dehydration, they had sepsis, they had pneumonia, whatever. And we measured the NGAL before they were admitted to the hospital and asked the question, can that admission NGAL, even before the patient reaches the floor or the ICU, can that predict who's going to get into trouble with AKI, defined as a consistent, sustained increase in serum creatinine for 3 days at least? And the answer is yes. These are the buckets of patients that we adjudicated 3 days later. So clinically, after 3 days, we could determine who had chronic kidney disease versus pre-renal azotemia, meaning increase in creatinine that was reversed with fluids and other treatments for 3 days, or true structural consistent, sustained acute kidney injury. And these are the NGAL levels on the y-axis. And you can see very clearly that these patients who ended up having true structural acute kidney injury 3 days later, we could make that diagnosis even before they were hospitalized, even before they were admitted, with an AUC of 0.95. I mean, give me a break. Can't get any better than that, right? And very high positive and negative predictive values. Nobody believed it. Beginning to sound familiar? But now we have many, many more papers and many thousands more. And in this recent meta-analysis, what they looked at was every possible biomarker that can either predict or exclude acute kidney injury in patients who are critically ill, who are admitted to the hospital. And that's the list of all the biomarkers. And right on top there, 27 publications so far, many thousands of patients across the world. That area under the curve and diagnostic accuracy has stayed extremely high. In fact, so high that the NGAL was used in this meta-analysis as the top reference point for sensitivity, specificity, and diagnostic odds ratio. And they compared it to this reference point, and the only one that came really close to it is serum NGAL. 20 publications. So again, stood the test of time, stood the test of repetitive measurements of all biomarkers, and all looking at the same outcome. Clearly, the urine and plasma NGAL outperformed the other biomarkers. Nephrotoxins, we all use them all the time. And this was the first study done in kids again, looking at 91 children with complex cardiac lesions. They got contrast for diagnostic purposes. And we just measured urine and blood NGAL before and after. Same AKI definition, 50% increase. And when you give contrast and you get contrast-induced nephropathy, that again, using creatinine is delayed by 1 to 3 days. The creatinine doesn't go up for at least 1 day. Look what happens to the plasma NGAL or the urine NGAL. Within 2 hours of giving the contrast, the patients that subsequently got nephropathy or contrast-induced nephropathy had a dramatic increase in both plasma and urine NGAL. And the area under the curve is 0.92, 0.91. So the clinical scenario is you've given contrast, you've done your diagnostic study, get a drop of blood, drop of urine, check the NGAL. If it's high, you can be 92% sure who's going to get an increase in serum creatinine 1 to 3 days later. So think about what you can do in terms of planning, resource utilization, and so on and so forth. Nobody believed it. But now they do, because now we have this huge meta-analysis. It's called an umbrella review. So there are so many studies done on contrast-induced nephropathies and biomarkers. There are already 12 previous meta-analyses. And now this is a meta-analysis of those meta-analyses. I didn't even know you could do that, but apparently they can. But and they looked at all possible biomarkers. This is a huge publication. And what it showed is, look at all the biomarkers. These are the top 4. And once again, NGAL is right on top with an area under the curve. Many thousands of patients, more than 0.9, much better than anything else. And here on the right, you're looking at every possible factor known to man that can predict or put a patient at risk for kidney damage after contrast. And you go down and up and down the list, there are biomarkers there, there are clinical factors there, and the top of the list, again, is NGAL. No 2 ways about it. So stood the test of time. The accuracy has remained high in multiple people's hands. All right, we talked about differential diagnosis, right? Can I differentiate who has true structural AKI, which needs to be treated in a very different way, from a patient who has an increase in creatinine and a functional AKI, which of course needs to be treated in a very different way. And so we looked at that. More than 1,600 patients admitted from the emergency room in 3 different, it's a multi-center study, measured urine NGAL prior to admission, and we defined the intrinsic structural AKI as a sustained more than 3 days of increase in creatinine, and a pre-renal AKI as a patient who had an increase in creatinine, but you guys took great care of the patient, gave fluids, gave pressors, and the creatinine went back down. Can that admission NGAL, before all this happens, can you use that admission biomarker to predict which way these patients are going to go? Yes, the answer is absolutely yes. 3 days later, we could differentiate them into CKD, pre-renal AKI, and true intrinsic structural AKI, meaning the patient had an increase in creatinine that was sustained. And look at that NGAL, way too high compared to everybody else. And I put this blue dotted line there correlating to an NGAL value of 150. So that is the cutoff based on all the published studies. So anybody above 150 has true structural AKI, below 150 does not. That's what we learned from this. And the area under the curve, again, was very high. Prognosis, who's going to need dialysis? Again, lots of studies that have now been published. Here's a recent meta-analysis looking at every possible biomarker, including NGAL, as a predictor of acute kidney injury requiring dialysis, meaning patient gets admitted to the hospital, to the floor, to the ICU. Can you use that admission NGAL value to predict who's got the sickest AKI and will therefore need dialysis in the next 3 days, in the next 7 days, in the next 4 weeks? It doesn't matter. Can you use that? And yeah, the answer is absolutely yes. There's been more than 20 publications looking at both plasma and urine NGAL. And the admission NGAL to predict subsequent dialysis requirement has an area under the curve of more than 0.8, 0.82, 0.84. So that's telling you that when you have a patient rolling into the ICU, if you get the NGAL, it tells you who is at highest risk for getting or needing dialysis. So imagine what that can do to you in terms of resource utilization, in terms of planning, in terms of talking to your patients, in terms of talking to all the consultants who are going to add more and more nephrotoxic injury to these patients. Stop those patients at high risk for needing dialysis. Can you use biomarkers like NGAL to determine what's the best time to start renal replacement therapy in the ICU? And this is a complicated slide, so I'm going to go through it. This is a study that we did in our ICU. Patient gets admitted to the ICU and gets a clinical risk score calculated. We call it the renal angina index, but basically it's a combination of well-known risk factors. Is the patient hypotensive? Is the patient septic? Is the patient on the vasopressors? Is the patient 10% fluid overloaded? Is the patient already have an increase in creatinine? All of these tell you that this is a sick patient from the kidney standpoint. So we create a score. We don't do it. The EMR does it. We don't even think about it. And the EMR does it and calculates the risk. And if the risk is high, the EMR automatically orders a urine NGAL. No doctors, no nurses, nobody's involved. It's already done. And so when I round in the ICU in the morning, I know for every patient what the MAP is, what the oxygen saturation is, what the NGAL is. It's calculated and automatically measured. And if that NGAL is normal, even in a patient who is at high risk for AKI, our ICU docs will just continue their awesome standard clinical care. They won't even call nephrology, even if the creatinine is elevated. They don't need to call nephrology. But if that NGAL is elevated above 500, even if the serum creatinine is normal, they're going to call us because that is a trigger. That is telling, the writing is on the wall. That's telling them that this patient is going to get into trouble in the next 3, 4, 5 days. Let's be proactive. And we have an arrangement with the ICU such that if these patients with high NGAL level have either a 10% fluid overload or just an increase in NGAL above 500, consider starting early renal replacement therapy. In other words, don't wait for the fluid overload to be 30%. Don't wait for the creatinine to be 10. Don't wait for the potassium to be 8. Just an increase in the biomarker in a clinically predisposed patient is adequate for the ICU to call me and say, start dialysis. So we did that and we studied it for several years. And this is what we found. This is published just recently. These are the different characteristics of the patients. This is pre-taking focus 2, which is patients who were treated as routine standard of care before the biomarker. And then this is post TF2, which is patients treated as using a biomarker to start early dialysis. They were all very sick. They had same Apache scores, same PRISM scores. They were all equally sick. But the difference here is that we had the agreement to start dialysis early based on a very high biomarker level at admission. What did we find? Well, the first thing we found here was that, let me see. Yeah. So the time to start dialysis was much less when we used the biomarker. That makes sense, right? We didn't wait for the patient to be fluid overloaded. And, we don't wait for patients to be apneic to start to intubate them. Just like that, we didn't wait for these patients to have a fluid overload of 30% and getting very sick. And so we started within 2 days of ICU admission, whereas the standard of care was 4.5 days. Very, very different. And what's the outcome? Look at the survival. Survival to ICU discharge. 65% of patients who started early dialysis survived, whereas the ones that got standard of care, 46% survived. Very, very statistically significant. So we had a fluid accumulation benefit, we had a survival benefit, and total stay in the ICU, which much less when we started dialysis early based on a biomarker measurement. 13 days versus 24 days. Equally sick patients, right? But in that subgroup of patients in whom the writing was on the wall, we did not wait for apnea. We used biomarkers to intervene early, and this is what happened. Tremendous advantage in terms of survival as well as ICU stay. And then our hospital administrators were very happy when they saw that doing that, we were able to save the hospital more than $12,000 per CRRT patient. And that again makes sense. We've started dialysis earlier. They need less dialysis. They need less ICU stay. They're dying less on us. It all makes sense. But these numbers really clinches the deal for thinking about early measurement of biomarkers and acting on them in an interventional way. Okay, you got a patient who's on dialysis. I've practiced nephrology for almost 40 years, and I still don't know what the right time to stop dialysis. It's trial and error, okay? Can we use biomarkers? And again, the answer is yes. There's about 5 papers published, and there are ongoing studies, including here by Dana in the ICU setting. Can we use biomarkers to help us decide when can we stop dialysis? This is one example. This is an adult study. They're critically ill adult patients on CRRT. They were followed after CRRT discontinuation. Excuse me. And that occurred at the discretion of the ICU physician and the nephrologist, right? We use clinical judgment and say, okay, maybe we can stop dialysis now. They measured urine NGAL at the time they stopped dialysis and 6 hours after they stopped dialysis. And the primary outcome was, can they stay dialysis free? Or do they need to go back on dialysis? That would be failure. The recovery group would stay free from dialysis. That's like taking a patient, extubating the patient, and asking the question, what are the chances of needing reintubation? Terrible, right? Just like that, stopping dialysis and needing to restart it is not good. What they found was that using their clinical judgment, 22 patients recovered, but 32 patients, so more than 60% of their patients, needed to go back on dialysis, despite their best clinical judgment. And these are ICU and nephrology docs. 60% need to go back on dialysis. That's terrible. That's like reintubating 60% of your patients. Can we use a biomarker to predict who's going to continue to be in the recovery group versus not? And the answer is yes, because the urine NGAL was much higher in the non-recovery group, in the group that did not recover and needed to go back on the dialysis. And it predicted non-recovery at the time of stopping dialysis with an AUC of 0.8. So if you're thinking about stopping dialysis today, just check the NGAL, and if it's still high, don't stop it. Just wait for another day. That's the moral of the story. And there's about 4 or 5 papers. No meta-analysis yet. We're not telling you to abandon serum creatinine. No, We're telling you to use it in addition because NGAL provides this added value. And that was nicely shown by this very large 10-center study, pediatric and adult, where we looked at urine NGAL at ICU admission. We defined intrinsic AKI the same way we always do. And we were shocked to find about 20-25% of the patients were biomarker positive, NGAL positive, but their creatinine was normal. And so we asked the question, what is that telling us? These are patients with subclinical structural acute kidney injury. The functional damage is not shown up. But at the point of ICU admission, can we use that data to determine what we're going to do? And we were really surprised when we saw this. All very sick patients, okay? Very high Apache scores, very high SOFA scores, thousands of patients. If their NGAL and their serum creatinine was negative or normal at the time of ICU admission, they did pretty well. Look at that, very low hospital mortality, very low composite requirement of dialysis and hospital mortality. Very sick patients, but if their kidneys are not damaged, they're going to do fine. Just tells you how important the kidneys are, okay? Because what happens when you have a structural injury marker for these patients? Their creatinine is still normal, but they have subclinical kidney injury. Look what happens. Their mortality goes up by 4-fold. Their renal replacement therapy requirement rate goes up by 5-fold. And you can make this diagnosis by checking this marker at the time of ICU admission, and tremendous prognostic value. Much more than if the creatinine was elevated. If the NGAL is normal, these patients do okay. And that's because they just have functional injury. You can reverse it. You can give them fluids, you can give them pressors, and they will do fine. But once you have structural injury, you've got to take care of that. And so we put all this together in a cartoon, which I love. Goes from no normal function in the left to dysfunction on the right, and goes from no injury to structural injury from bottom to top. And most of us live here in the C-suite, which is normal urine output, normal serum creatinine, no biomarker in the urine. So these are normal kidneys, right? See what happens when this kidney starts developing dysfunction. Your urine output's going to go down, your serum creatinine is going to go up, but your urine biomarker is going to stay normal. And what that tells us is that there is no structural injury, no tubular damage. This is functional injury. These are patients with either volume depletion or mild cardiac problems or maybe too much diuretics. Don't even call the nephrologist. I don't care what the creatinine is, because this is something that ED and ICU and hospital medicine can handle very well. You can give them fluids, you can give them nephrotoxins, you can do a CT scan with contrast, whatever you want, because those kidneys are normal, even if the creatinine is elevated. Very powerful, right? But what happens if there's injury without functional damage? They will still have normal creatinine and normal urine output. And we will be fooled if we didn't measure the urine NGAL, because if we did, it will tell us that these patients have those subclinical acute kidney injuries. Please treat them seriously, because that is a harbinger of bad outcomes. They're going to need dialysis. They're going to die on you unless you intervene early. Unfortunately, most of our patients in the ICU are here. Their creatinine is already up, their urine output is already down, our urine biomarker is way high in the thousands, and there's mayhem. And these are our patients with sepsis and severe injury, for whom right now all we can do is supportive care. But we really need to move the dial here or here. So measure both the functional and structural biomarkers, put them together, and nobody can fool you. Okay, there's always a question of cutoffs. And I showed you, looking at all this data, and these are all meta-analysis of NGAL studies, and you can see many, many thousands of patients, many, many thousands of AKI events in all sorts of settings, critical care, cardiac surgery, contrast, sepsis. When you do a meta-analysis of all these meta-analyses, what we found was that, first of all, diagnostic accuracy is very high. Cutoff of less than 50 effectively rules out structural AKI. I'm not worried about what the creatinine is or what the BUN is. If the urine NGAL is below 50, don't call nephrology. But if it's above 150, and if a patient is at risk for AKI, call nephrology, even if the creatinine is normal, because this is an early warning signal and it predicts structural AKI. So we've used all this, say, for about 7 years. And recently, we took all of this data, I mean, this huge amount, hundreds of thousands of patients, presented to the FDA and said, please, will you clear this biomarker for us? And they sent us back home. And they said, no, because when you design a study for FDA clearance, you have to do a separate study. You have to have an indication, specific platform, a feasibility study, a cutoff study, and a validation study. This is what it takes to convince the FDA. And they're doing this because they're worried about safety, right? They don't want people to measure biomarkers and trigger therapies unless we know the biomarker really works well. So fast forward 5 years, we've been able to do all this, and we've gotten the FDA clearance for children 3 months to 21 years of age. And it's for AKI prediction in these patients. And it says specifically use the Roche clinical platform because that's how the FDA works. But the fact is, you can use any standardized laboratory platform. You can use the Roche machine, the Siemens machine, the Becton machine, whatever machine. It works equally well in all of them. It works in any machine that can measure your BUN and your creatinine and your potassium. And a multi-center, 15-center studies in progress for FDA clearance in adults, so that we're hoping will come out soon. And the turnaround time of this test, I can get it faster than I order a stat potassium, 15 to 20 minutes. And luckily, you guys have it. You guys have it. It's a standard. You can order it in any patient that you suspect is at risk for AKI, and you will learn, just like we have learned in the last 7 years, how best to use this marker. So this is our approach. First question is, who should get tested? Please don't check everybody in the ICU, right? Because, for example, if you measure troponin in the ICU, 50% will be positive. 50% of the ICU do not have MIs. It's a false positive measure. So if you measure it in everybody, you'll get a lot of false positive. But first thing we do is we be good doctors. We do clinical phenotyping, right? A good biomarker will not make a bad doctor good, but it'll make a good doctor better. So clinical phenotyping. So in our setting, these are patients at risk, and the critically ill patients, obviously, patients with complex cardiac surgery or prolonged bypass time, patients are already fluid overloaded because that's a cause and a consequence of AKI, multiple nephrotoxins, be it contrast antibiotics and transplants, including kidney transplants. And so these are the patients that we automatically check NGALs on. And how do we use it? Remember, these are patients at risk for AKI. They may even have an increase in serum creatinine. But if the NGAL is normal, you don't need to even call nephrology. Kidney damage, you've already ruled it out. So you continue your beautiful standard care. You safely use as much fluids as you want. You can use diuretics. You can use nephrotoxic medications. You can do a CT scan with contrast. You can do whatever you want. Don't worry about the kidney. But if it's slightly elevated, that's a gray zone, and we'll repeat it in 24 hours. But what if it's moderately elevated or trending up? Even if the serum creatinine is normal, if the patient is at risk for AKI, that predicts either current or future kidney damage. It's coming. So we follow NGAL levels. We initiate what's called as the KDIGO bundle, which is that same group of smart people that have said that if you have a patient at risk for AKI, do this, 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 this. And what they say is adjust the fluid therapy, of course, so that you don't get fluid overloaded. Adjust potential nephrotoxic interventions. Consider invasive monitoring, certainly Foley's, maybe CVP, and consider calling your friendly nephrologist. What if it's severely elevated, right? In the thousands, or going up from 200 to 1,500? That definitely predicts severe kidney damage. And we'll do all of that, but we'll stop any nephrotoxins. We'll definitely start invasive monitoring. And these are the patients that will early consider renal replacement therapy, just like that study I showed you. If there's a clinical risk factor and the urine NGAL is high, we don't wait for severe clinical manifestations of AKI. We will start renal replacement therapy early. And then if the patient's on dialysis and now the NGAL is trending down, that's great news because that predicts recovery from kidney damage. We will stop the dialysis. We'll stop other kidney support medications and we'll follow NGAL levels and we will allow the kidney to recover. The worst thing you can do to a recovering kidney is to continue dialysis. So stop it. Here's a biomarker that tells you to stop it, and you will almost always be right. We're getting to the end of it. So patients at risk for AKI, low NGAL values, don't worry about them. Give them fluids, give them diuretics, give them nephrotoxins. Yeah, monitor for worsening AKI, but don't worry about the kidneys. But even if their creatinine is normal, if they're at risk for AKI clinically, and if the NGAL level is high, those are the patients that require fluid adjustments, invasive monitoring, nephrotoxin removal, early nephrology consultation, and like I showed you, early dialysis consideration. Here's the test, okay? I hope you've been paying attention. What's the time? Do we have time for a test? Yeah, we do. Okay. True stories, okay? This is the patient undergoing cardiac surgery. 14-year-old boy, critical aortic stenosis, underwent surgical repair with CP, a cardiopulmonary bypass, 120 minutes, and 3 days later, he developed oliguria, edema, increase in serum creatinine, clinical AKI. Sound familiar? Yeah, your ICU is full of these patients, right? And you all know that there are multiple clinical risk factors. There's aortic stenosis, there's long bypass. Bypass itself is risk factor and long bypass time. This tells us clinical phenotyping, this patient's at risk for AKI. So patients like this, we will monitor the NGAL. And that 4-hour postoperative urine NGAL, the creatinine was normal, it was 395. What's your take on that? You're not allowed to leave unless you pass this test. Just kidding. So that predicted for us this patient had structural AKI, right? And so we monitored the urine output, daily creatinine, urine NGAL, stopped nephrotoxins. This patient was on a bunch of nephrotoxins. Stop those, assiduously maintain blood pressure, hydration, and start other preventive medicines. And we did all that, yet 3 days later, the patient developed clinical AKI. The cardiac surgeon was calling me and saying, let's start dialysis. I said, let's get an NGAL level. And it was 80. What's that telling me now? I can fight the cardiac surgeon. I can say, hey, look, this patient has recovering AKI, even though right now he has an increase in serum creatinine. That's the real result of a damage that occurred 3 days later. This kidney is already recovering. We're going to hold off on CRRT. And turns out that we were right, because over the next 2 days, this patient became polyuric, the edema went away, creatinine normalized. So you can use it to initiate preventive measures and also use it to avoid invasive treatments if that NGAL level is going down. Here's a slightly more complicated story. 18-year-old pre-med student, true story. These are all true stories. Appendicitis, suspected perforation, didn't take care of himself, was too busy in medical pre-med studying, but he then underwent emergency abdominal surgery, and initially he did okay. And 3 days later, he developed sepsis. And what do? We give them broad-spectrum antibiotics. 4 days later, he developed clinical AKI. Decreased urine output, 10% fluid overload, increase in serum creatinine. Yes, again, multiple risk factors to start with: suspected perforation, abdominal surgery, sepsis, nephrotoxic antibiotics. This is the patient that definitely needs serial NGAL measurements, and that's what we did. Here's what we saw. In the first 3 days, it was about 300. Even though clinically he did well, creatinine was normal, but he had an NGAL level that was high, and that told us, hey, let's be careful about this. This is diagnostic for structural AKI. We stopped the nephrotoxins, we controlled the blood pressure, kept him well hydrated, and this one didn't do that well as compared to the cardiac surgery patient because he developed sepsis. Serum creatinine was still normal, but now the NGAL is 3,900. What do I do now? That's diagnostic for severe structural AKI. We changed the antibiotics, very tight blood pressure and fluid control, decreased the fluid so that they don't get fluid overloaded, and we started talking to the family about needing renal replacement therapy, even though the serum creatinine was normal, right? And yeah, we did the right thing, because the next day, his creatinine went up a little bit, 2.6, not an indication for dialysis, Fluid overload of 10%, not an indication for clinically for dialysis, but the NGAL is now 6,000. The writing is on the wall. Let us start dialysis. And we did. We started dialysis early. He got off dialysis in about 3 days and he recovered completely. So you can use this biomarker not only to predict structural injury, but to predict the severity and to determine who we can start dialysis. One more very quick story, a very true story. A kidney pathologist from a very famous US hospital on vacation with his wife, 20-year-old anniversary, okay? He presents to the emergency room there in Italy with vomiting, some diarrhea, and they measure the creatinine as 3.5. Okay, famous kidney pathologist. So he calls a famous nephrologist from his famous US hospital who says, oh my gosh, come home right away. You need a kidney biopsy. I need to start dialysis. You probably got interstitial nephritis. You probably got... In walks a very kindly ER doctor and says, your urine NGAL is 42. What's that telling you? He was given IV fluids. He was sent back to his hotel. The next day, his creatinine was normal. He fully recovered. He happily completed his vacation and saved his marriage and sent me an email saying exactly this. This is paraphrased from the email that he sent me. Thank you for discovering NGAL. You saved my marriage. And that is where we are going with these biomarkers. And this is, I believe, my last slide. Patients at risk, I hope I've convinced you, we measure the NGAL. If that's normal, you give them standard of care. But if it's high, there are a number of interventions that you can study and compare it to placebo. And the idea will be that if your treatment works, that NGAL is going to go down and you're going to get less AKI. So you can use the biomarker not only to cherry pick your patients to start treatment, but also to predict who is going to respond to therapy. Yeah, the placebo patients are going to continue to have high. So this is the paradigm that we're using, testing multiple interventions, such as early dialysis in our institution, and many folks are doing this. This all takes not one, but multiple villages. Okay? These are just acknowledgement of my early adopters, people in the first 3 years, 25 years later, who listened to my crazy ideas and said, yeah, maybe we should try this in our own setting. And this is all over the world. And these are patients who are still using NGAL. And now in the US, there's 150 centers that are using it, including yours. So congratulations. Very grateful for all the funding I've received from my institution, AHA, NIH. And in the yellow box, I've put 3 companies that have worked closely with me. And the take-home message is that please do not hesitate to work with industry, especially in these days of FDA, NIH turmoil. They need us and we need them. And so please be very open about collaborating with industry. These are the people that took my crazy ideas, put them onto standardized machines, got FDA clearance. They spend $25 million getting this from the bench to the bedside. So I'm grateful to them, and I'm grateful to all of you. Thank you for your attention. Happy to answer questions.